Hi friends, Pradeep Pindyala, Professor of Anesthesiology. Today I am going to discuss with you a very important condition that is called how to save a life by giving defibrillation. Yes friends, it is very important thing to be learned. If you are a doctor especially, it's a must. And I'm going to tell you a few things which many doctors might not be knowing, although they think that they know how to give a defibrillating shock. If they have even given cardiac defibrillation earlier, still in my present lecture, they might find few important new points which they might not be knowing. So let's start. Let me try sincerely to bring out some important topics. So, as you are aware, cardiac defibrillation is normally administered for when there is cardiac arrest because of ventricular fibrillation or pulseless ventricular tachycardia. So, the definitive treatment of ventricular fibrillation is definitely electrical defibrillation. Defibrillation is very effective to treat ventricular fibrillation, provided it is done as early as possible. When the defibrillation is delayed, every 1 minute would decrease the chances of survivability by 10%. Now, what is exactly this? Ventricular fibrillation occurs when normal transmission of cardiac impulse is interrupted. That's how ventricular fibrillation occurs in a heart. This can occur because of ischemia, it can occur because of myocardial infarction, it could be because of electrical shock. If somebody receives an electrical shock, they develop ventricular fibrillation. That's how they die. Or somebody blows him on the chest. That causes ventricular fibrillation because of severe injury. Or they could be because of R on T phenomena. What is R on T phenomena? If ventricle is still contracting and the phase, depolarization has become is given when the T wave is still forming. If it is superimposed on the previous beat's repolarization phase, that causes severe cardiac fibrillation. So that's why, friends, you should never give defibrillation shock to a normal heart or when it is not indicated. By this, you will per se would cause ventricular fibrillation and patient may die of cardiac arrest, although he had no chances of this happening. So you should be very careful. As I had mentioned, it is done only in two places, like ventricular fibrillation as well as pulseless ventricular tachycardia. If it is very high pulse, that is it altogether different thing. And if the cardiac arrest has taken place because of asystole, you don't give defibrillation. So you have to be very careful where it has to be done. So that's why normally only a trained person should be in charge of giving cardiac defibrillation. Even if I tell the normal lay person, they may not be successful. Yes, automated external defibrillator has come in a big way. It is self-generated. The verbal responses would come. It will tell what is to be done. Those things can be used. Now, AD are there all over the airports, and even on every flight, ADs will be available to save lives. But you should know how to use it. I'll be telling you how it is used. So, as I just mentioned, if R on T phenomena occurs, ventricular fibrillation can occur. And sometimes there are syndromes, prolonged QT, prolonged interval. So that also can cause, like Torsades pointus and all, that also can cause ventricular fibrillation and death. The chaotic dysrhythmic firing which occurs in fibrillation, once you see that, you will never forget. And what happens? Ventricle contraction is not enough to produce adequate cardiac output because of ventricular fibrillation. Now, this results in cardiac arrest. This is how it takes place. So, what is to be done? I said definitive treatment of VF and pulseless ventricular tachycardia. Pulseless ventricular tachycardia is only one treatment is there, that is electrical defibrillation. Now, many people think when defibrillation is given on the heart jump starts and start working. No, many people think that way. Now I'll tell you exact what happens while you give defibrillation. See, what happens actually, it produces, when the defibrillation is given, it produces a nearly simultaneous depolarization of the entire myocardium. That causes momentary cessation of all entire cardiac activity. Now, there will be a viable heart intrinsic muscle somewhere in the heart. So after this, after a little pause of few seconds, spontaneous initiation of the electrical impulse takes place. That is how defibrillation works. Very few people know exactly how it works. Now, widespread availability of automated external defibrillator AEDs are available all over the places. Everywhere AEDs are available, most of the places. So, you have to be trained how AED to be used. You have to interpret ECG by automatically it interprets, and the shockable rhythm is present or not, it interprets, and it charges by its own and for the required energy level. And what you have to do is just press the button of shock. That's all, and defibrillation works. Now, what are the things? As I have mentioned, ventricular fibrillation and pulseless ventricular tachycardia only are two places where defibrillation is to be done. Is there any contraindication? Absolutely no. Even if you have pacemaker in situ, or you have implanted cardiac defibrillator already in the heart, still you can get defibrillation. What you need is a defibrillation machine with a cardiac monitor, or as I just mentioned, automated external defibrillator, AED. Now, this has to be done preferably by medical personnel, and otherwise you should be trained how to be using AED. AED usage is very, very simple, and it can be done very, very simple, provided you spend little time in learning how to use the AED. Now, defibrillator paddles are placed on the chest. Where are they placed? There are two paddles. One is placed upper right sternal border, and another is placed at the cardiac apex. And hands-free defibrillator like AED, the hands-free pads are placed in the same location as I have just mentioned. One at the upper right sternal border and the other at the cardiac apex. If the child is very small or something, and even one paddle cannot be placed adequately, and two cannot be done on the anterior side, so one can be placed anteriorly, the another paddle can be placed posteriorly. That is cool. That is known as anterior-posterior configuration. So that is how it has to be done. Now, the cardiac monitor and defibrillator capacitor is charged once you press the charge machine. Once the capacitor is adequately charged, what you have to do, you have to just press the button after putting the paddles at the places which I had just mentioned. In biphasic defibrillator, in fact, right now, all the defibrillators are biphasic. In my time, 20 years back, only monophasic defibrillator used to be available, where we used to give 300 joules. Many people call joules, it is joules. But now, with the biphasic defibrillator, you have to select 120 joules to 200 joules. The American Heart Association recommends giving the maximum available dose. So don't forget that. So once fully charged, at that particular scene before giving the shock, please make sure you announce that you are giving shock so that everybody leaves it. Otherwise, unnecessarily, normal people surrounding the patient can be shocked, and even death can take place. So be careful when you're delivering the shock. Once the shock is delivered, please continue CPR. CPR is nothing but cardiopulmonary resuscitation. That has to be continued. Resume it for 2 minutes. Give it perfectly, nicely, and after 2 minutes of high quality CPR, see whether the patient has regained normal pulse or not by palpating, or see on the cardiac monitor whether the impulses are coming or not. If it has not come, you can give one more defibrillation. Now, what is to be done? If VF or pulseless ventricular tachycardia persists, immediately the patient should be resumed, and as I mentioned, the stepwise increase of the defibrillation dose can be done, or highest dose to be selected. Now, ventricular tachycardia or pulseless ventricular tachycardia, ventricular fibrillation treatment, the American Heart Association has outlined one algorithm. As per that, once you have given a shock, nothing is happening, is not improving, the condition is not improving, you have to give 1 milligram of epinephrine. Epinephrine is nothing but adrenaline. 1 ml is there in 1 ampule of 1 milligram. You can dilute it with 9 ml of normal saline and make it 1 in 10,000 and give. What you have to give is 1 milligram of epinephrine every 3 to 5 minutes. High quality CPR to be continued after each shot. And if VF and pulseless ventricular tachycardia is still persistent, please inject 300 milligrams of amiodarone. If the next dose to be given amiodarone, you have to give 150 milligram of amiodarone. All this bolus doses. And amiodarone, if it is not available, you can go for 1 milligram or 1.5 milligram per kg body weight of lidocaine. You must have heard Zylocard, lidocaine or lignocaine. That has to be given. But preferably, as per the American Heart Association guidelines, you give epinephrine and amiodarone rather than giving lidocaine. Now, coming to pediatric cases, would you give the same amount of dose like 200 joules in biphasic and 360 joules in monophasic defibrillator? No. You have to give 2 joules per kg. In subsequent defibrillation, if the pediatric patients are not improving, you can give 4 joules per kg. Maximum dose is 110 joules per kg. Now, infant pads are needed in patients under 10 kgs, less than 1 year of age. Normally, if it is not available, pediatric attenuator can be used. And in children who are 8 years of age or less than 25 kgs, AED with pediatric dose attenuator can be used. In children, if they are more than 8 years or if they have 25 kgs or more weight, the standard automated external defibrillator pads and the normal electrical defibrillation of adult dose can be given. In case the ventricular fibrillation and pulseless ventricular tachycardia occurs during thoracotomy, that's in the department of cardiac surgery, you don't give external defibrillation. I'm sure very few people know about that. That's what I was trying to say. Now I'll tell you a few interesting things which many people may not be knowing. If ventricular fibrillation and pulseless ventricular tachycardia occurs in a department of cardiac surgery or thoracotomy, what you have to give is altogether different. The internal defibrillation has to be done. The dose is just 20 joules. That's all. If it is more, it can cause burns. Care should be taken to avoid coronary vessels, obviously to prevent vessel damage. And subsequent doses can be increased to maximum 40 joules. And needless to say, it has to be sterile internal pads that is to be used. I hope I have brought out some interesting points, and I hope it was a very interesting lecture. Until next time, take care. Good night. Bye-bye.